Welcome to the introduction to the LMA Fastrach. The LMA Fastrach is a device which can be used either blindly or with fibroscopic guidance to intubate a patient. What's useful about one, at least useful aspect of the device is that it allows ventilation via the LMA during the procedure. As such, it's useful for cases of anticipated or unanticipated difficult intubation, or any time when conventional laryngoscopy is undesirable. The components consist of endotracheal tubes. The normal adult-sized endotracheal tubes are either the 7, the 7.5, or the 8.0 millimeter inner diameter sized endotracheal tubes. They're reinforced, and any one of the normal adult-sized endotracheal tubes works with either the LMA 3, 4, and 5 are designed for use in small, medium, and large-size adults, respectively. The other component is a stabilizer bar. The stabilizer bar, endotracheal tube, and laryngeal mask are all marked with depth markers which allow correlation with anatomic structures. In addition, there is a longitudinal black line on the endotracheal tube, which is designed to face the handle, and a transverse black line. And the transverse black line corresponds with the depth at which the tip of the endotracheal tube encounters the bar, which displaces the epiglottis during placement. Prior to use, the cuff integrity of both the endotracheal tube and laryngeal mask should be checked. The endotracheal tube cuff should hold pressure. And in addition to holding pressure when overinflated, the laryngeal mask cuff should remain flat when it's fully deflated. Like that. The LMA surface should be lubricated prior to placement. Following induction of anesthesia, the patient can be either mask ventilated normally, or the laryngeal mask can be placed immediately. Following placement of the laryngeal mask, the cuff is inflated, and I like to check for a cuff leak. About 10 centimeters of water or more of leak is desirable if positive pressure ventilation is going to be utilized. In addition, it's important to remember not to use the handle as a lever against the teeth, although sometimes a gentle rocking motion can help seat the LMA properly. Once the LMA is placed and proper depth of anesthesia is ensured, muscle relaxant can be administered if so desired. It's not required if depth of anesthesia is great enough. The endotracheal tube can be placed. Can be placed, again, either blindly or with fibroscopic guidance. Lubrication is very important. I find it useful to make sure I twist the lubricant all around the channel of the LMA before placing the endotracheal tube. Once the tip of the LMA encounters the bar, which displaces the epiglottis, the vocal cords are encountered about a centimeter and a half to 2 centimeters past that point at which the black line meets the metal cuff. Of course, the endotracheal tube should be placed without undue force. It should pass easily. Sometimes there's a little catch at the point at which the tip of the endotracheal tube passes the vocal cords. Once the endotracheal tube is placed, the endotracheal tube cuff is inflated. Placement is confirmed using the usual combination of breath sounds, end-tidal CO2, and again, possibly bronchoscopic confirmation. If desired, the LMA can be left in place with the endotracheal tube in situ, or the LMA can be removed. If it's desired to remove the LMA, the connector to the endotracheal tube is removed. Very easy device to lose. In a pinch, connector from a conventional endotracheal tube can be used. The LMA is removed again while trying to keep the endotracheal tube as stable as possible. Stabilizer bar is just there to hold place, if you will. Once one can reach around inside the patient's mouth and grab the end of the endotracheal tube, the stabilizer bar can be removed. The endotracheal tube can be removed. The connector replaced. Placement of the endotracheal tube can be reconfirmed using breath sounds and capnography, and again, fibroscopically if so desired. And at the end of the case, the patient is extubated using normal and usual practices and criteria for extubation. In LMA Fastrach, we have a healthy 120 kilo patient who needs ureteroscopy. We give an induced anesthesia as usual, and Dr. Mayfield is ventilating her with a mask, and she has adequate anesthesia. She has muscle relaxant on board, and we're going to put in the LMA now. It's an LMA 5, the largest size. Looks like it's seating well. Put in 40 cc's of air. We're going to check for our leak.
It's above 40.
Okay, it's above 40 centimeters of water. Perfectly adequate, certainly adequate to ventilate through if need be. Okay. After ensuring adequate depth of anesthesia, we'll now pass the endotracheal tube. This can be done with or without a fiber. Why don't we do it without first? Black line is towards the patient's eyes, forehead. You often feel a catch at the vocal cords. Feel a catch or not? Or?
Yeah.
Okay. All right.
Get into position there.
Okay. You want to hook up and turn on the DES. Okay. We've inflated the endotracheal tube cuff, deflated the laryngeal mask cuff. She seems to be ventilating adequately. We've got end-tidal CO2. Stethoscope? Sorry. Okay. All right. Pass a fiber and confirm placement. You'll have a view right there. Let's see, do I need to turn the brightness up a little bit? I want to give her a little desk too. Okay. We can confirm that there are bilateral breath sounds. There are bilateral breath sounds. All right. You want to pass this guy?
Yeah.
Okay. Kill tube. There's the Murphy eye. We go past. Now stop. That's the carina. So we're above the label of the carina. Those are the tracheal rings. Okay. You come on out. Why don't you ventilate her a couple times, and I'll give her a little more propofol, and then we'll All right, sure. Go ahead. So this is the stabilizer rod. We take the endotracheal tube connector out. Be careful not to lose it. Stabilizer rod. You want the curve going that way if you can get it. I know it's hard. There you go. You're getting it. There you go. You're almost there. If you can't get it, it's okay. The main thing is that the tube not come out, that you keep pushing it. There you go. You got it. Okay. So Dr. Mayfield is going to advance the stabilizer rod while he, or actually hold it in place while he removes the LMA component. Keep pushing this in because otherwise, if we... Then Dr. Mayfield will reach around, grab the end of the endotracheal tube, remove the stabilizer rod. Pull the Fastrach cuff out. Reconnect. What's our distance there, Scott? Will you turn the desk back on? I'm sorry, what?
24.
All right, let's pull back just a centimeter. Okay. Equal breath sounds bilaterally. So if we want, we can now reconfirm that we have not, that we're still in the trachea and that we're above the level of the carina. Scott, you actually don't have to take the connector off, but
Okay.
let's see. You want to direct that?
Yeah, I got you.
Okay, and there's the carina again. So we confirmed with breath sounds and we confirmed videographically that we're still above the level of the carina. Okay, why don't we reconnect?